Well, good morning, everybody, and thank you for coming to this lecture. And thank you, Bev, for inviting me to do this. And last summer, when I got the email inviting me to do this, I responded, yeah, sure, great, I'll do it. And then I thought to myself, how am I going to make this interesting? And what am I going to show everybody that they haven't seen already or that they don't know about? And Joe, everybody who was here for the last lecture has seen everything you need to see, probably. But I always like to survey the audience before we start. How many people have ever seen a cyst in an ovary? Come on. All right. How many people have seen a mural nodule? And how many people have seen a septation? All right, good. I'm done. That's all there is to it, all right? So then I thought, well, I've always had the philosophy that if you don't think something is interesting, you probably don't know enough about it. And so I started reading and learning some stuff about it. And then I realized I really didn't know a whole lot about this compared to what's really out there. So I promise you a lecture like nothing you've really seen before. And we're going to go over some interesting stuff here. And what I'm going to do is we're going to talk about ovarian development. We're going to talk about the physiology of the ovary, both premenopausal and postmenopausal. We're going to talk about what happens during menopause that makes things change. And yeah, we'll talk about some ultrasound stuff, fluid, ovarian enlargement, cysts, masses. I guess you can't really give a talk about ultrasound of the ovary without at least talking about this. But we're really going to look at the literature and some of the pitfalls and problems with doing this. And then, of course, the real subject here is screening for ovarian cancer. And I discovered I didn't really know a whole lot about this, and I'm hoping that when I'm done with this lecture, you'll know something about this as well and be able to put all this into context. So we're going to talk about developmental biology, all right? And you're probably wondering to yourself, why would somebody who's talking about postmenopausal ovary start by talking about the developmental biology of the ovary in a fetus? Okay, anybody have any idea why? I promise you I'm going to tell you. Okay, I know we hear this a lot on TV lately that you're going to hear things, but I promise you I'm going to talk to you about this. So first of all of us basically start off as a 3-layer embryo. Okay, and if you remember this from your developmental biology days, we are ectoderm, mesoderm, and endoderm. And what developmental biology, what we are good at is making tubes. All right, so we make concentric tubes. Your CNS is a tube, the cardiovascular system is a tube, the GI tract is a tube. But there is an exception to this, okay? And the only cells in the body that aren't formed from these 3 cell layers turn out to be gametes, okay? Gametes and peritoneal lining. Okay, and so when we're a little embryo, we're all little chickens, and we have a yolk sac. And here's the yolk sac here connecting inside the body of the embryo. Here's endoderm, mesoderm, ectoderm. Okay, cells develop inside the yolk sac that actually migrate up into the peritoneal cavity of the embryo. And along with this, the lining of the yolk sac enters as well and actually develops along the inside of the GI tract. And this is going to be the future peritoneum. Okay, and you can see various stages of development here, but the real exception here are spermatozoa and oocytes, and they form from different cell line than everything else. Okay, well, why do we care about that? Well, I'm going to tell you why we care about that eventually. So here we go. We have these little cells that are going to be gametes. All right, they're moving up from the yolk sac, they're moving into the peritoneal cavity, and they settle, okay, in these urogenital grooves is what this is called here. Okay, and on this schematic, this is aorta here, this is the kidneys, there's a little glomerulus here, and some tubules. So this is going to be the kidney. In cross-section, this is going to be the GU tract, this is going to be the GI tract, the aorta, and here we are developing our ovary or our testes right here. And these cells that are going to be the gametes work their way up from the yolk sac and into the peritoneal cavity. And of course, early on, the development of the ovary or the testicle is very similar. Okay, and the difference that occurs is really the plumbing, the tubing that connects these organs to the rest of the body. And we know that the Wolffian duct is ultimately going to end up forming the vas deferens, all right, and the Mullerian duct will regress, whereas in a woman, the Wolffian duct regresses and the Müllerian ducts are going to ultimately form uterus and cervix and vagina. Now, one big difference between ovary and testes is that the testicle is much more vascularized, actually. The blood supply to the ovary is much less prominent, actually, than in an ovary. Okay, so we start off, okay, this is what an ovary looks like to begin with. We're on the urogenital groove here, and we have a lining of epithelium, okay, and then we have this basement membrane, and then we have the stroma, okay, and this is really important ultimately because this thing is what starts, okay, and then ultimately gametes, ovaries, oocytes, populate this structure, and they form, and this becomes more organized, and you have oocytes, you have stroma, and then you have this basement membrane. Okay, and so these are really the three cell types that are in the ovary, and these are the three types of cancers we're really going to talk about later towards the end of the discussion. But it's important to recognize that the ovary is a little unique in that this part of the ovary actually projects into the peritoneum. Okay, and keep in mind that the peritoneum also developed along with these oocytes, okay, because this is going to mean something ultimately. So you have, it's quite a bit like a tree. And the fruit of the tree, the oocytes, is really in the peritoneum, okay, whereas the stroma and the vascularity are really originating from the retroperitoneum when they enter the ovary. And ultimately, this is what a mature ovary would end up looking like. Okay, and this is important to recognize, and I'm going to go over this later, is that this is epithelium. This is the most common kind of ovarian cancer, is epithelial, but you can have germ cell cancers as well, less common, and then you can have stromal tumors as well, and we'll come back to that in a second. Well, all of us just heard about the premenopausal ovary. Terry gave a wonderful lecture, and we all know you have primordial follicles, they mature, ultimately they rupture. They ovulate, you get a corpus luteum, and then if fertilization and a pregnancy doesn't result, they degenerate. And these are the hormone levels that go along with this. This is luteinizing hormone, follicular stimulating hormone. Okay, you get a peak of luteinizing hormone, and that's when ovulation occurs, is right here. And this all comes from the pituitary, and the pituitary drives this, all right? And then this is estrogen and progesterone. And you notice estrogen, it has two peaks. Okay, there's the secretory phase, or the proliferative phase peak rather, and then we're at secretory phase, and this falls a little bit, and then it peaks again basically towards the end of secretory phase prior to menstruation, whereas progesterone really occurs just before ovulation, okay, and this is what really allows the endometrium to receive an embryo if one is formed. So that's premenopausal physiology, okay? What happens in postmenopause? Well, in postmenopause, instead of having this cyclical process, a lot of these oocytes basically begin to degenerate, okay? And they become atretic, and we get small, basically non-functioning oocytes here, okay? And more of these start to develop. The ovary atrophies, and then we just end up with tiny little residual material from these oocytes, okay? The hormone levels, on the other hand, because we're not making estrogen and progesterone anymore, the pituitary gland gets quite upset about this. There's no feedback inhibition, and our follicular stimulating hormone and luteinizing hormones increase their levels throughout menopause. And so menopause can be defined basically as elevated levels of these pituitary hormones and very low levels of estrogen and progesterone. All right. Well, the reason I put this really busy looking slide in here is for a couple reasons. But one is this statement up here. Okay, so what is menopause? All right, seems reasonable to define it. Menopause is caused by depletion of primordial follicles in the ovaries. Okay, females have a maximum number of oocytes at 20 weeks of gestation. All right, so that's a clue as to why I talked about embryology a little bit. So the follicular pool decreases gradually throughout life until about age 52 when the pool runs out. So when you run out of active oocytes, that's when menopause occurs, okay? Most women will produce roughly 50,000, 100,000 to maybe even 1 million oocytes during fetal development, but only 500 of them will ovulate. And the remaining ones that never ovulate, that never do anything, are called the oocyte burden. in these patients. And then if you look at these charts, these are the pathways of what occurs with these hormones. And the only thing I want to point out is what I said before: elevated follicular stimulating hormone, way high, okay, in postmenopausal women. Increased luteinizing hormone, way high in postmenopausal women as well. Okay, and this is all going to be related ultimately to the imaging of the ovary. Okay, and so we get these things called breakthrough cysts, and then what happens is these immature oocytes, and here's a clue, that happen to have double-strand breaks, induces ovarian epithelium to form tumors. All right, so we're going to get back to all this in just a second here. So the postmenopausal ultrasound exam in many ways can be considered the hunt for ovarian cancer. I think we all know that. We don't see most of the premenopausal stuff like dermoids and endometriomas and things like that in postmenopausal women, right? And so there are really 4 things that we really talk about and look for when we do the postmenopausal ovarian ultrasound exam. We look for ovarian size. Okay, these ovaries atrophy because they don't have mature oocytes in them anymore. So usually they're less than 5 cc's in volume. Okay, pretty small. Normal might be 12 during active ovulation, maybe up to 20. We do look for cysts. We're going to talk about cysts. As a distinction, we talk about cystic masses. Okay, and cystic masses are masses that have mural nodules, projections, septations, debris, echogenic fluid within them. And then we're going to talk about ascites as well. So these are really the ultrasound findings we're looking for, and this is really the basis for doing the ultrasound exam. So what I did is I went through the literature, and if you go through the literature, there are 50 to 100 articles published every year on various aspects of this subject. And so literally there are thousands of articles going back over time. And what I did is I took all the ones that were done within the last 6 months just to point out where we are in this. And I want to just point out some of the issues and problems that we keep seeing in the literature. So here's one. 99 postmenopausal women, 42 had surgery, and what they were looking at is what's the mean size of the lesions that they see when they're screening, okay? 5 cc's is the cutoff here. Well, what they found was that the majority of these were solid benign tumors. These are all stromal tumors in general, and the vast majority of them were benign, and then there were 2 invasive carcinomas in this series. So I think we know that increased ovarian size is a real marker for malignancy. The problem is we'd like to find them when they're small. Okay, this is the problem. And I don't know what size cutoffs people are using when we call them normal, but the real dilemma is if normal postmenopausal ovary is 5 cc's, what do you do when you have a 10 cc ovary or 20 cc ovary? And when do you become concerned about it? And what do we do about it? So I'm going to just talk about cysts for a second because cysts are a bit of a dilemma. And so I quote to you, this is the American College of Obstetricians and Gynecologists practice bulletin on the management of adnexal masses, and this is really in postmenopausal women. It's in 2015, and it says, with the exception of simple cysts on transvaginal ultrasound, most pelvic masses in postmenopausal women will require surgical intervention. Okay, so does this mean it doesn't matter what we say? If there's a mass, it's going to be taken out ultimately? I mean, this is what they were suggesting in 2015. So a group was formed to deliver a consensus report. Okay, the first international consensus report on adnexal masses, management recommendations. Okay, and you know, in Seattle we have a football team, the Seattle Seahawks, you know, and the defense is called the Legion of Boom. And if you look at the names on this consensus panel, we have Phyllis Glank here. Is Phyllis here? She was here at one point. We have Phyllis, we have Beryl, we have Beverly Coleman, we have Deb Levine. I mean, this is clearly as good a defense as you could possibly have representing the SRU, right? So what did they find? And what were their recommendations? Well, they found that in the United States, we perform 9.1 surgeries per malignancy that's discovered, okay? In European countries, based on their data, it's 2.3 surgeries per ovarian cancer found. In most centers around the world, it's 5.9 surgeries per ovarian cancer. So we have the distinction of doing the most surgeries per ovarian cancer found. And I don't think that's surprising, actually, the way our system is set up. So the panel concluded that patients would benefit not only from a more conservative approach to benign adnexal masses, but for optimization of physician referral as well. So it seems that most of the lesions that we're going to find are benign, okay, especially when they're simple cysts, and that we're doing too many surgeries per malignancy that's found. And so we all know that we developed an SRU criteria for following cysts, and in the postmenopausal arm of this, most of these come back for follow-up for anything bigger than a centimeter. Okay, when you're premenopausal, they can be bigger, but right now we're following every cyst that we see. Okay, I'm missing a slide here, but that's okay. So that's the recommendation now, and this is what the gynecologic surgeons wanted us to do. Now, we're going to make a distinction here between cysts and cystic masses. Okay, so a cystic mass has septations and nodules and plus or minus flow within them. And I'll just go over a couple of the data. Again, this is very recent. This is 2014. And this was the performance of ultrasound as a second-line test, the screening with CA-125. I said we'd talk about screening, and we will. 741 women, 1,219 cancers. This study was done over almost 7 years. And when we see these, ultrasound sensitivity was 100% for abnormal morphology, 90% for abnormal volume, and the highest specificity and positive predictive values were found for these findings. So ultrasound is very, very good at doing this, okay? So the question becomes, why don't screening programs using ultrasound really work, okay? If we look at another paper, they basically developed a scoring system, and there have been lots and lots of scoring systems published in the literature for how to evaluate complex adnexal masses. Beryl published one. She has a scoring system of her own, but they pretty much have the same features. Cyst wall structure going from smooth to thick wall to papillary projections to solid, septa, thin septa, thick septa, solid areas within the septa, okay, and then the volume of the tumor. And you notice that you have to start getting pretty large before you get higher in the score here. So I think all of us here are very familiar with this gradient, if you will, of how suspicious a lesion is based on size and particularly based on papillary projections. Okay, papillary projections are more worrisome than septations in general. And I just throw this in here. We all do flow in these lesions. If a lesion has a mural nodule in it, it doesn't really matter whether it has flow in it or not. In a postmenopausal woman, it's going to be taken out. Okay, so this is the original paper. Thomas Bourne published this, 50 women. And I throw this in here. 7 out of 8 had cancer, had low RI flow. These were the kinds of things you could publish 20 or 30 years ago. Now I'm going to show you more literature to give you the kinds of numbers that people talk about. We're going to talk about the presence of ascites. Now, what I was really looking for, what I wanted to know is how much ascites needs to be present before you start worrying about the presence of an ovarian malignancy or particularly peritoneal disease. And so this paper from 2007, 372 patients with ascites specifically had cytological studies, and their survival was evaluated, and it was very clear that ascites is associated with omental metastases and metastatic lymph nodes. Okay, and I think we all know this. Okay, and so the question I really wanted to know was, what if I see 1 or 2 cc's of ascites in the cul-de-sac of a postmenopausal woman? Okay, is that suspicious? Okay, should that make me start looking around? Should that make the gynecologist do something to this patient? And I can tell you that I did not find a single paper that addressed that issue. Okay, and yet for me, if I do one of these exams and I see a tiny amount of ascites, it makes me worried. Okay, postmenopausal women really shouldn't have ascites. So whether I see an ovarian mass or not, or peritoneal disease, I'll report ascites, and I think these women have to have increased surveillance, certainly. And then that brings us to the final part of this, and that is the biochemical screening for ovarian carcinoma. And everybody is familiar with CA-125. Everybody's heard of CA-125, right? We use it all the time. What are the problems with it? Okay, the problem with it is that there's a lot of things that do it. Okay, in premenopausal women, it doesn't mean a whole lot. Endometriosis can do it, fibroids do it, PID, menstruation, hyperstimulation, pregnancy. Okay, and then there's a lot of non-gynecologic fat things that can elevate CA-125. CA-125 is really a marker of epithelial cells. Okay, and so things like congestive heart failure, renal disease, liver disease, appendicitis, pneumonia, pancreatitis, all of these can elevate CA-125. So the value it seems to have is it raises some suspicion in a postmenopausal woman that a malignancy could be present, and it's probably a better marker to follow as the woman gets treated than it is for really confirming that a patient has a malignancy here. And if you look at all these different markers related to epithelial cells, okay, you see CA-125 right here. Okay, it doesn't have great sensitivity for ovarian cancer, okay, at least in this data, which is from 2017, by the way, all right, about 13%. There's others of higher sensitivity, okay, but it does have the highest specificity, okay, so if it's elevated, well, this is even higher actually, but it does have high specificity. So again, it's very useful for following tumors, but it's not so useful as a screening test in and of its own right. Now, how many people here have heard of BRCA1 and 2? Everybody's heard of this? Nobody's voted. It's like any other election, huh? Okay, people have heard of these, right? Okay, how many people really know what these do? Okay, how many people understand what it is that the genomics and proteomics that we're talking about for screening for cancer do? Okay, well, I didn't, I'll be honest with you, until I started looking at this. So what these genes do is they code for proteins that repair double-stranded DNA breaks. Okay, and I mentioned this in the very beginning, okay, about embryogenesis here. Okay, when do double-stranded DNA breaks occur? They occur during meiosis. Okay, they occur when the oocytes are developing. Okay, so why is it that we are screening for ovarian cancers for something that occurs during oogenesis, okay, for something that's a follicular disease, okay? There's a little bit of a paradox there. It's an epithelial disease, okay? It's not really a gamete disease, ovarian cancer, all right? And so, but what happens is you have these double-stranded breaks, okay, and then these cells are abnormal, and then ultimately when these cells start growing and become a cancer, all of these proteins that are supposed to be trying to repair these breaks multiply, okay, and they're elevated, and then this is how we're screening for ovarian cancer. I will point out that this is genetics of the BRCA1 and 2, and this was the original family who had the history of breast cancer, and the black, of course, are the ones who were infected. And by tracing these genes through this family and doing genetic studies on them, this is how the BRCA1 and 2 genes were developed. So basically, BRCA1 and 2 repair, homologous recombination repair, that means double-strand breaks. This only occurs during meiosis. Okay, and this is not the only incident time where something that occurs during developmental biology leads to disease 50 years later. The other big one is hypertension. Okay, all of us are born with all the nephrons we're ever going to have when we're neonates. Okay, and if you have fewer nephrons than you're supposed to have, even when you're a little baby, that actually predicts quite accurately who's going to get hypertension when they're age 50. The problem is, how do you count nephrons in somebody? It's not possible. Well, the same thing is happening here with the ovary and ovarian carcinoma. Okay, and so there are 4, and this is the only process that can repair double-stranded breaks, the only process that's known at the moment. And so there's 4 genes necessary to do this, so this forms the basis for the genomics that people are studying. And then there's all these proteins that get together. Here's our double-stranded DNA break, and we have telomere maintenance and homologous end joining and all this stuff that we don't really know about as radiologists. But here's our double-stranded break. Here's our complex of proteins forming a little bridge here and pulling the ends of this together, and this is how these get repaired, okay? And this occurs during meiosis. So what is the pathogenesis of ovarian carcinoma? And this came out blurry. I had actually replaced all these slides this morning, so all my new ones didn't get in here. But anyway, this is our surface epithelium. And just to emphasize that the formation of cysts in the postmenopausal ovary does not follow this oocyte ovulation pattern. Okay, it's a different process. Okay, in postmenopausal women, they don't have any active oocytes anymore to ovulate. So what happens is you get these inclusion cysts of epithelium. So there's little breaks in the surface of the ovary where the epithelium maybe has some kind of crater in it or some kind of ridge or irregularity. A little bit of epithelium gets trapped within the stroma of the ovary, and then this forms a cyst. Okay, and so then the question is, how is it that an epithelial cell like this, okay, ends up forming an ovarian cancer where all of the proteomics and genomics that we're looking at are for gametes, for oocytes, okay? There's no oocytes in these. Well, the answer to this is that all those little cells that migrated out from the yolk sac during development, okay, seed the peritoneum, seed the fallopian tubes. Some of these have double-stranded breaks. When these cells form, when these cysts form, some of these get a little inclusion of some of these cells within them, and it's these cells that then grow into ovarian cancers. Okay, and that's the paradox. So how is it that if you don't have any oocytes left, that we're screening for cancers, looking at oocyte-type genomics? And what this says here is epithelial cancers are the majority of the cancers. Terry said the same thing. Germ cells do not form ovarian cancers in postmenopausal women. This is younger women. And then the stromal tumors, by and large, produce hormones and manifest much earlier as well. So that is really the genesis, if you will, for ovarian cancer. It is actually double-strand breaks in the oocytes that are migrating from the yolk sac, okay, up along the peritoneum, okay, and then forming the ovaries. So here's the problem. Here's some literature, very recent literature here. Well, this one's from 2000, but it illustrates the problem. 14,000 women were screened, so 46,000 screening years. Okay, we looked at volume, mural projections, only 17 cancers out of this group and 3 deaths. And while every cancer and every death is too many, this isn't very many, right? It's a pretty small volume. And then when you look at the literature, look at the numbers of patients these people are reporting. You know, Tom Bourne reported, 50 patients with color flow, 34,000, 50,000, 48,000. And yet look at the number of cancers here. Very small, 34, 24, 27. Most of them were stage 1 and 2, but here's the problem. Some of them really were stages 3 and 4. So we're looking at something that doesn't happen that often, okay? And even when we're screening for it using chemistry, genomics, proteomics, and ultrasound, a lot of the patients that we find still have advanced disease. And maybe this is the problem. Okay, this is an older study that really illustrates the issue. 22,000 women underwent screening. Only 40 were positive. Okay, out of the 40 that were positive, only 11 cancers were found at surgery. So there's 30 false positives. So we really are overcalling this in most of these women. And then the real issue is the 8 false negatives. 8 women who were screened in this study went on to have ovarian cancer, and that's the problem. And that's what I see in my own experience, is you'll do an exam on a patient, and it's totally normal. 6 months later, a year later, she comes back and has metastatic disease, and I find that very frustrating. Okay, and then this is more data, and you can look in your syllabus at this, but it says the same thing. Huge numbers of patients, small numbers of epithelial cancers, okay, and at various stages, all right? And so this is a problem, small numbers, all right? And yet, small numbers of cancers for large numbers of women screened. So there's been several groups that have published recommendations for ovarian cancer screening. This is from the New England Journal. And what does this one say? Does not recommend routine screening, does not recommend routine screening, does not recommend screening, does not recommend screening. Okay, this is why, is because it just doesn't really work very well. So it's not something we should really be trying, all right? And I don't like getting that phone call either. Grandma died of ovarian cancer, can you take a look at her ovaries? That makes me nervous, frankly. So contrast, okay, this is the big hope for the future, and small ovarian malignancies do have greater peak enhancement and longer washout times than normal ovary. Here's a little tumor here, all right? And there's been 10 independent studies, 579 ovarian tumors, and the pooled sensitivity, 91%, and specificity, 92%. And of course, Art Fleischer authored one of these papers, and he was just telling me this morning there's even more papers out. So maybe contrast will help us in this situation. I'm going to show you, these are the only images I'm going to show you in the study. Here's a patient I did, 50-year-old woman, asymptomatic, came in for ultrasound exam, okay, took these images, thought this was a cyst, and I thought this was reverberation artifact, and maybe it is, all right? But I said, come back, this is 5 centimeters, you need to come back in 3 months and let me look at this again. Well, she didn't come back, she never showed up again, and I'm just about to run out of time, but I'm almost done here. So she never came back. 9 months later, she shows up. Now she's symptomatic, and she's got mural nodules within the septation. She's got low resistance flow. And of course, this turned out to be an ovarian cancer, and it was stage 3 by the time we picked it up. So I can tell you that 25 years later, this bothers me. It still bothers me. It's the only time I've ever seen this happen in my own experience. And then this is the strangest cancer I've ever seen. This had all this strange material in it, big mass. Nobody would mistake this in a postmenopausal woman for anything benign. And it turned out it was stroma ovarii. It actually had thyroid tissue in it. So it's a very strange case in reality. So anyway, in conclusion, I just want to really emphasize that the event that results in ovarian cancer occurs during embryonic meiosis. Okay, as odd as that may seem, that's really when it happens. The peritoneum and the ovary are intimately related. Okay, and it explains the spread of peritoneal disease. The ovary forms along with the peritoneum. The cells move into the peritoneum, and it's no surprise that that's where a lot of the metastases go. Biochemical and genetic screening stratifies risk, and yet it's still not really routinely recommended for screening for ovarian cancer. We're familiar with the worrisome findings in ultrasound. That's why I showed you all this other stuff rather than images. We still overtreat simple cysts. Okay, really, simple cysts, the pathogenesis of these is inclusion of epithelium in the ovary. It's not ovulation, and this, just the cyst in itself, if it doesn't have the right cells in it, is not going to form a cancer. And in my mind, be wary of fluid. I think even small amounts of fluid are worrisome, and maybe contrast is the great hope here. And I thank you very much for your attention.